posterolateral tibia. So again, you've done the same motion palpation. Okay, the tibia has gone lateral, or it has gone medial, and it's rotated posterior after it's gone that way. It's the same motion palpation. Move the patient out on the edge of the chair, move it back and forth, find the fixation. It's going lateral to medial. We're going to correct this in the prone position, so have the patient lay face down on the table.
Oh.
What we're going to use primarily as our contact point is just our chiropractic index finger. We are going to reinforce it with our other hand and our other fingers as much as possible, but to get specific in there on that, you really just want to use this particularly when it's posterior and lateral, because we have to be proximal to the fibular head. Okay, everybody got that? So we're going to bring the patient's knee up and try to get it up to 90, so you may even want to have the patient move down towards you. Okay. Come up here. Here's the fibular head. We have to be proximal to that. Make our contact. Get your body into position. Remember, the patient's ankle always goes where? Medial shoulder. And so bring your forearm into the position. Your line of drive is S to I or P to A, however you want to think about it, and lateral to medial thrust. Okay? If it's gone medial and rotated posterior, same thing. Here, I'm just now going to move out here. I'm going to take my contact on this medial, on the posterior portion of the tibial condyle, as proximal as I can get, and get my forearm in position and thrust this way. Okay. You guys need to show me, do I need to show you the contacts on these? For the tibia, if it's gone rotated anterior, you're contacting on the anterior medial, if it's medial, or anterior lateral, if it's lateral portion of the tibial condyle. If it's gone posterior, it's on the posterior. You can just do that. Posterior lateral or posterior medial portion of the tibial condyle. Okay. The next one we're going to do is going to go straight across here, and that contact is for what misalignment? Straight posterior tibia. And while we're here, when we're contacting the fibular head, if it's anterior medial, we're going to contact the anterior, anterior lateral portion, or the posterior lateral portion, depending on which of the misalignment is. Okay, now we'll stay right here. So if it's gone straight posterior, we're not going to do the rocking motion palpation. We're just going to do our Deerfield test, right? And we're just going to have the patient lay prone. And let's say Eric is having trouble with his right knee. We're going to bring this up into this position. We're not going to get as much flexion out of that knee as this one. Okay? We're going to come up, make our contact. We're going to get as right along the posterior portion of this tibial condyles, the lateral medial one. You're going to use your basket weave contact. Get down in that joint as much as you can. Remember, you're not pulling up here. It's down here, and it's a scooping type mechanism, like almost like you're adjusting an AS occiput. Okay? Take out your slack and thrust.
And that's a posterior.
That's a straight posterior tibia. Straight posterior tibia. Okay? For the fibular head, I'm going to want you to motion palpate it like this. We're just going to do a pumping action where we're going to put the patient into dorsiflexion with some eversion or plantar flexion with some inversion. And we're going to feel that rise and fall. Okay? That's the motion palpation I want you to do. You can do the other one on your patients. We just don't have time to do all these motion palpations where you just have the patient sitting up, their knee bent, their foot flat on the table, and you grab a hold of it and you shove it back and forth to see if you can find any fixation. Okay. So if it's gone posterior and it's gone lateral, then what we're going to do is come this way, very similar, almost identical to what we did with the lateral and posterior rotated tibia, only now I'm going to be up on the fibular head, and instead of just using one finger as my contact finger, we're going to use two. Use it almost like the what do they call that on the baseball glove? Anyway, the web, thank you. And I'm going to put it right here, get a hold, reinforced with this hand. The fibular head is stable between my two fingers, and Okay? Everybody got that? If it has gone, and we'll shift over to the left leg. Let me have you sit up if you would, Eric. If it has gone anterior and lateral. The same motion palpation, though, you have to put the patient prone first and then get him back into this position. Then you're going to come over, you're going to find the fibular head, you're going to use a big flat part of your thumb here. We're not trying to do it like this. We're not trying to get in it like this. Just a nice big flat comfortable thumb on there. Hold on to the patient's calf. Put your other thumb on top of it, and your line of drive is going to go anterior to posterior and lateral to medial. Okay?
You're not stabilizing that foot or anything?
I don't find it's necessary. If you feel that you're working on somebody and you think that, just stick your leg up like this. Press on it. Whenever you're adjusting somebody, you want to make sure they're stable. And if you're setting up and something's not right, do something about it. Is that all?
What's the motion palpation again for tibia if it's going posterior medial or posterior lateral?
It's the same. We're going to rock it. Yeah, and you're going to have to pick up the rotation where? X-ray will help you. Mechanism of injury. Or if you can even look at it. Sometimes you can look at somebody's and you can get a pretty good idea by looking at the musculature, etc., how that's rotated.
The straight posterior is the one where you're doing like the leg check.
That's right.
The motion.
And again, your history will help you with that. They're walking along and their dog ran into them or something happened. You know, a dog can take the fibular head out too. You know, some of you play with these big dogs running across the park and they can run you over. You know, they're so happy. Yes, sir?
We're motioning the fibula,
Yes.
and we're just feeling it move.
You're just, that's all we're doing is feeling that move. And the restriction is going to be it's not going to move as well. It's not going to tell us if it's anterior posterior.
Okay, so why would you want us to do that over actually moving it anterior?
I think you get better motion and a better understanding if there's any fixation in the joint. And in your office you can do both. But I really think that to really feel the joint move and to find that, and of course that's what I've always done, you know, so that's what I'm most familiar with. So when I want to